block HoLEP with early apical release. This is Fernando Gomez Sancha. I'm going to show a semi-live case using the Quanta System Holmium 150 watt laser using the virtual basket pulse modulation setting at 2 joules, 50 watts, classical settings for holmium enucleation. The patient is a 67-year-old man with bothersome LUTs who has been on duodart for 8 years with a normal PSA and a prostate on ultrasound of 85 cubic centimeters. So the procedure starts with a very careful cystoscopy, trying to avoid bleeding, and we're going to use a 550 nanometer reusable fiber from this system. Here you can see the sphincter is a little bit, sorry, the apex is a little bit asymmetric, and initially the procedure starts with the marking between the sphincter and the apex of the adenoma. This is called, I call this the white line. Is a line that you demarcate as a surgeon. There's no other anatomical clue about the sphincter than the sphincter itself. So you have to look at the anatomy and decide where you're going to mark this white line. That will guide you for the rest of the procedure. Initially, I tried to make a circumferential line that goes over the verumontanum, now just cutting the mucosa and all around the adenoma to delineate the limit of the operation from the beginning. This is going to be the capsular localization maneuver on this side. Usually I like to do a little bit of this mechanical dissection at the edge, but of course you have to make sure that you cut the attachments of the sphincter and the apex posteriorly first, because this way you create some space that gives you some access to go in there and do again this maneuver on the other side. So, but always, you know, cutting these fibers. You can enter the plane with energy dissection sometimes, but in this occasion, I thought it was a good idea to develop this plane on both sides, so we have a very clear anatomical reference of where the operation is starting. This is the section of the frenulum of the veru, crossing the midline, so we can have one single posterior plane. Once this space is developed, I like to turn the fiber, to put the fiber at 12 o'clock, which is going to be my static fiber position during the operation. I think keeping the fiber in this position throughout the procedure makes the procedure simpler. You don't have to be moving the camera, you don't have to be moving the fiber around, and it makes the procedure more simple. Now, this is the line of attack. This is the line of attack. It's going to be always in the center of the image. So you have to position your scope, center it with this line, the line of attack. So you can always see half of the screen with capsule and half of the screen with adenoma. Working with this wide line of attack makes the procedure simpler, and it helps you decide where the plane is when you cannot see where it is because the anatomy is not so clear. So it's nice to have this uniform line, and here you can observe the effect of this pulse modulation setting. You know, the holmium energy typically is absorbed by water, so it doesn't reach very far, but you can see that I'm using the fiber a little bit apart from the tissue, and it's providing me with excellent dissection of the plane, and at the same time it's providing me with an excellent first pass hemostasis. This means that I can focus on the dissection of the plane and the anatomy. I don't have to be worrying about fiber, the rotation of the camera, or keeping actively the hemostasis, because this pulse modulation technology allows us to operate in better conditions. This enhanced holmium laser energy that provides better cutting and better coagulation is helping to develop the plane with excellent visibility, and of course making the operations faster. One of the other things that I think is going to be facilitated by these lasers is the learning curve. You know, if you don't have to worry so much about bleeding during the operation, learning this procedure seems to be easier. We haven't got data yet, but we have the clinical impression that teaching the procedure with this laser is much easier than with a normal holmium, because whoever is using it at least can see properly and is not anxious with the control of hemostasis. Also, of course, this en bloc technique with early apical liberation has many advantages, and one of them is the excellent irrigation. This excellent irrigation of a very small space provides also very good visibility even when there is mucosal bleeding. So whatever we did in the posterior aspect, so the liberation of the posterior aspect of the apex, we have to replicate now anteriorly. So initially I'm going to do this cut, which seems to be cutting on the adenoma. You see, I'm cutting on the adenoma, I'm deepening the white line that I did at the beginning. And I do that to get more access, so I can really look for the good plane and do the dissection of the apex, but without causing excessive stress in the external sphincter. So it's very important that this initial incision allows to dissect this relatively complex anatomical space, you know, the anterior limit of the sphincter and the apex, with a little bit more easy and especially more safe conditions, because by cutting these attachments of the sphincter and the apex initially, we get better access, and of course we can work safeguarding the sphincter's mucosa. We have realized that the problem with classic HoLEP techniques that would dissect the adenoma without looking at the sphincter, without looking after the sphincter, would often cause a deepithelialization of the external sphincter, which could cause early postoperative stress incontinence. Now, with this careful early apical liberation and sphincter's mucosal preservation, we see that stress incontinence is a very rare occurrence, even in patients with large glands. This is the 12 o'clock limit. We hadn't marked all the way up to 12 o'clock. And here we can see that if we continue dissecting the lobe the classical way, maybe this little curtain that we can see there of mucosa would become much larger and would deepithelialize the external sphincter. So it's important to keep on the, see, that's the sphincter surface, that's the sphincter's mucosa, and it's important to avoid the generation of this curtain of mucosa. That means that the mucosa has a split, has broken, and is leaving the sphincter probably intact in terms of the muscle fibers of the sphincter, but without the mucosal lining that is responsible for providing a perfect seal for postoperative continence. So here we're coming up on the other side. I like to connect the planes. So when I'm doing the lateral dissection of the apex, I like to connect it to the posterior plane we did before. This is going to make things much easier later. And then as we come up, you have to be very conscious of the position of the sphincter. And when you ascend in this dissection, you have to start cutting more horizontally. It's very important to cut these fibers so we can take the line of attack a little bit more proximal, further from the sphincter. And then once we have separated this apical anterior attachments to the sphincter, we can then focus in following the right plane, looking for the best, most eccentric plane that will allow us to remove the whole adenoma. Doing these incisions doesn't mean that you're going to leave any significant amount of tissue attached to the sphincter. So these technological advancements, the pulse modulation that we have seen initially with the Moses Holmium system from Luminis, and now with this virtual basket setting from Quanta Systems, is changing everything. You know, it makes the holmium cut much better and become much similar to the cutting properties of thulium. So this laser cuts the very hard tissue, the very fibrous tissue, like the 12 o'clock fibers of the sphincter, much faster with excellent hemostasis. And these are the two features that the holmium, the modern holmium systems are now acquiring: the ability to cut much better and the ability to coagulate much better. So before, when I was using thulium lasers and green light lasers for enucleation, I was always missing the property of the holmium laser that provides this ability to dissect the plane following the anatomical route. And now with this enhanced cutting, I don't miss the thulium or the green light because of their properties. So I think holmium has been now enriched with properties that we liked from thulium and green light. And this excellent coagulation, excellent first pass coagulation, which means that as we dissect, the coagulation is already quite solid, quite good, is an excellent feature that makes our everyday life much, much better. One of the things that I have liked from this special console, it's a little bit bulky, it's quite big, and not especially, let's say, fancy in terms of design, but it's a big box, but it provides a very silent operation. And I think the lack of noise in the operating room is really, really a big joy. We are used to have a very big noise in the very high, noise in the operating room with other lasers. Even low power lasers sometimes are very noisy. But this unit is excellent in that respect. So I think it's going to be competitive in the sense that we can reuse the fiber, in the sense that it's very silent, and the tissue effect seems to be excellent. I have done now a number of cases with this laser, and I like it a lot because it allows me to carry out this circumferential dissection of the adenoma without having to worry so much for the bleeding. Of course, there's always cases, special cases, where there can be a little bit of bleeding because the vessels are too big, or the prostate is very vascularized, or, I don't know, the patient has a high blood pressure during the operation and it tends to bleed a little bit more. But in principle, the quality of hemostasis has been very much improved with this pulse modulation advances in the generators, in the new generators of holmium laser. So as you can see, this operation also needs a laser that can withstand continuous operation. You can see that I hardly ever stop working. This is why these procedures are very fast. Not only because the holmium pulse modulation makes the procedure faster, but because en bloc HoLEP is a very fast procedure. You don't have to lose time making incisions in the prostate. You right away go to the plane and right away start to develop the plane, and then the pausing time, the time that you are actually not lasing, is very, very, very little time during the operation. So most of the operation, you have to fire the laser, and I really like to be able to work like this continuously, seeing how I can improve the situation every minute. You know, things are getting better and better as we go. Here we have a circumferential line of attack. You see the camera is centered on the line of attack all the time, but we have to take into account that the direction of the plane is not always the same. So initially the plane is looking, let's say, towards the lateral sides, towards the posterior and towards the anterior, because the planes are opening up, let's say, the angles are opening up because we are dissecting a spherical structure or pseudo-spherical structure. In this moment in the operation, you see the bladder neck, for example, is not going down anymore. You know, the direction of the dissection is changing, and we can go around the adenoma, but we have to be very careful where we aim the laser so it doesn't penetrate in the capsule. And for that, we have to work against the line of attack, but keep the fiber a little bit on the side of the adenoma. You see, so you have to fire against the line of attack, but on the side of the adenoma to try to correct these planes that are not straight. The fiber is straight, but we have to dissect these planes that are not straight at all. So the way to adapt to the change in direction of the plane is to change the aiming. Initially we were aiming right at the line of attack. Now we are aiming a little bit closer to the adenoma. All right, so here we're trying to dissect downwards, and pushing the adenoma a little bit down, we can reach the bladder neck anteriorly. There is a steep change of the direction of the fibers, you see. Above we have circular fibers, but now we see vertical fibers, and this means that we are reaching the bladder neck anteriorly. We are, with our scope placed above the anterior commissure, between the adenoma and the capsule, entering the bladder anteriorly. I think this is the safest entry point, and I have to say it's rather constant to be able to see this change in the direction of the fibers, which is pathognomonically, you know, a sign that we are going to enter the bladder neck. So there's no mistakes there. Of course, I've done a lot of cases with this technique, and I feel very happy and familiarized with it. For those surgeons who haven't done it yet, I recommend them to watch the videos that I have posted online in YouTube to try to learn the steps and tips and tricks to develop the skills to be able to do this procedure fast and easy. And if you have post-operative stress incontinence, even when it's temporary, you have to know that this approach changes that completely. You will forget about incontinence in the post-operative period. Here in this drawing, I'm trying to depict the change in plane that I was mentioning, and how you see the fiber has to stay very close to the adenoma in order not to perforate the capsule and not to get with your dissection behind the trigon. Of course, it's nicer, you know, especially when it's a difficult plane. Sometimes it's very easy. You can always try to connect the sides. You know, you can connect the sides with the posterior aspect. So go from lateral to medial, because we know very well where is the plane laterally, and we can progress towards the midline and below the middle lobe to try to do a progressive dissection, careful dissection that doesn't perforate that part of the prostate. So this is the posterior aspect. We are about to finalize the enucleation of the prostate. There's only now an attachment at the bladder neck posteriorly, and because all the anterior aspect of the bladder neck has been already cut and dissected. Here we're coming up towards the more anterior aspect laterally, you can see that the behavior of the laser is amazing. Nowadays, we can finish these cases, for an 80-gram prostate. I think the total operative time in this man was something like 35 minutes. So it's really a fast procedure. We can progress faster and faster with experience, and it really makes this procedure extremely attractive. We leave the catheter typically overnight and take the catheter the next day, but there are already studies with pulse modulation that show that this procedure can be performed in an ambulatory setting in a number of patients in selected cases. So I think the paradigm of HoLEP is changing. It's been here for quite a while, but there have been not only changes in technique, and a better understanding of the anatomy of the apex and the sphincter, on how to protect continence in the postoperative period, but also technological advances that make this procedure even more attractive. And I believe it is making this procedure much easier to learn. So that's, it doesn't mean that you don't have to work, for this procedure. So here you can see how the bladder neck is being cut lower and lower until we can get under the middle lobe. You see, under the middle lobe, and we can leave the adenoma hanging from the bladder neck at 6 o'clock. We will be able to flip the adenoma into the bladder at some time. I have found that even in very large glands, it's usually possible to flip the adenoma by flipping one side first and then the other side, making a rotational movement of the adenoma to try to squeeze it into the bladder. That's the other side. Here also we're trying to connect the bladder neck with our dissection, the posterior plane with the lateral plane, and incise the bladder neck fibers following the circumference of the bladder neck. And it is really a pleasure to work with a laser that is now, I think, approaching very fast this this goal, or this dreamt tool that would allow us to do enucleation, focusing on the anatomy only, and providing excellent means to cut and coagulate, and also an explosive effect in the tip of the fiber that separates the plane following the anatomic route, following the path of least resistance, and allowing for an anatomical dissection that makes us feel that we are in the right plane all the time. We are removing the whole adenoma, and we can be pretty sure that the patient is going to have an excellent clinical result. We can do these operations typically under 1 hour, and patients go home without a catheter after a few hours and go back to their normal life after 2 or 3 days. So it's really, I think, the best procedure available for the long-term resolution of lower urinary tract symptoms due to BPH. That's the end of the procedure. There's always some attachments that have to be freed at the end. And now it's the time to try to flip the adenoma. You see that the capsule is very nice, very anatomic, and there's nearly no bleeding. Just maybe minor bleeders that usually happen at the bladder neck. That's the UO, and we had this little piece of tissue hanging there near the UO, and we have to avoid, of course, damaging it. And here, the mucosa very close to the sphincter was very close to the UO, was peeled off, but both UOs looked absolutely healthy, so no problem there. And the enucleation was finished. The good hemostasis means that you can move on almost straight ahead. When you finish your enucleation, you change to morcellation. And then, of course, the advances in morcellation have also allowed us to do very fast morcellation. I'm only showing the end because there's no time. But here you can see how the fossa remains without bleeding, and there is an excellent preservation of the sphincteric mucosa that will provide immediate continence for the patient.